Good afternoon, everyone. Thank you for joining us on the AAMI Summer Learning Series. This session is on medical device, IOMT inventory, and vulnerability platform selection. My name is John Burrows, and I'm a course facilitator here at the AAMI Education Department. Now, before we get the webinar started, I'd like to go over a couple quick housekeeping notes. All participant mics are muted throughout the duration of the session. Should you have any questions during the session, please use the questions feature in the GoToWebinar interface. A PDF of the slides are located in the handout section in GoToWebinar. The recording of the session will be emailed along with instructions on how to access it through AAMI's My Learning in the next business day. The CEU certificate will be available at the conclusion of the track. Each session is worth 1 CEU, and you can use the CEU tracker form provided. For a complete list of the Summer Learning webinar series, please visit our website. If you have any technical difficulties during the live sessions, please email online_meeting@aami.org, and a representative will be able to assist you immediately. Please note that AAMI's database will be down from July 23rd through August 1st. During this time, access to the store, LMS, and your profile will not be available while we launch our new database. Now, I'd like to introduce our presenters for the day. Please welcome our moderator, Thomas Finn, Director of Business Development at Medigate, Speaker Carter Groome, CEO at First Health Advisory, Speaker Jack Wagner, Vice President at First Health Advisory, and Speaker and Special Guest Travis Kobernick, Director of Clinical Engineering at Parkland Health and Hospital. With that, I will pass things off to you, Tom, and we can go ahead and kick things off.
Well, thanks so much, and good day, everyone. Thanks for attending. Just a few opening remarks, as I'm a major fan of today's topic and want to offer just a little bit of context. You clinical engineering and biomedical professionals on the call today work in the trenches, as they say, and knowing that you've had to perform in an exploding connected medical environment, never with adequate visibility, and now with added security practice pressures, continues to distinguish your workflows, challenge them, complicate them. Despite all of the talk of biomed, clinical engineering, and information security professional convergence, managing patient safety risks remains integral to what you do, and that remains a highly notable difference. But emerging network-based passive data capture and enrichment capabilities have raised expectations across the board. Put simply, the kind of visibility now available and the operational improvements that are now gettable are widely recognized as game changers for the profession. As you would also expect, health system buyers have responded. There's an interesting twist here, not just the typical dominant IDN early adopters, but health systems of all sizes are stepping up. They're finding budget, and systems, hospitals that would have normally waited several years until a vendor shakeout occurs and the surrounding knowledge base is more mainstream, are jumping in. As a result, you have buyers who candidly may not know what they don't know about some of these new capabilities and are therefore forced to rely on the word of vendors whose pitches all sound pretty much the same. And I'm not being casual about this. From the smallest community hospitals to the largest health systems in the country, major decisions are being made with minimal insight into the platform and its value to these health systems. So it's great that we've got First Health on board here today because they've been in the solution market from the very beginning. First Health has experience in these platforms, the building programs that leverage the vast amount of useful data coming from this technology. It has successfully carved out an advisory practice that helps its provider clients make the best decisions for their environment and get the most return for their investments. Carter, as CEO of First Health, why don't you take it from here and tee up today's real world conversation between Jack and Travis?
All right, thank you, Tom, and especially thank you to those who have joined us during really such an intense time for you and your colleagues. I'd say we're grateful to be partnered with Parkland and Travis's team as we've transitioned to building a comprehensive asset risk management program for the organization. And we hope that some of what we share here today will help you in your initiatives and things that you're considering in the future. And because we want to hear from you on this webinar, we've worked to balance the length of this presentation with more time for questions from you at the end. And so with that, I'm proud to turn it over to Travis. Thank you guys so much.
Thanks. Hello, everybody. This is Travis Kolbernick. Good afternoon, good morning, depending on what part of the country you're in. I'm the Director of Clinical Engineering here at Parkland Health and Hospital System in Dallas, Texas. We're a public hospital, a fairly decent-sized hospital in Dallas County. We have right around 900 beds, plus or minus, kind of changes on a weekly or monthly basis here lately, thanks to our COVID impact. You can see some of our demographics here. Our hospital was founded in 1894. Licensed beds, roughly 900. Discharges, annual discharges, 72,800. About 12,642 deliveries per year on average. About 21,023 surgeries per year on average. We have one of the busiest emergency departments in the country. The last couple of years, we've been ranked as the busiest emergency department in the country. This year, I believe this data here is from 2018, is 241,968 ER visits. On our network, since we have plugged the system in and went up and running, we have picked up over 35,000 devices on our network. 9,336 of those devices have been flagged or categorized as medical devices. The most common devices on our inventory are, of course, probably like any other hospital, it's our infusion pumps, our clinical mobile devices, our medical device integrators, patient monitoring, and medication dispensing, so on and so forth. Parkland, if y'all are not familiar, we got a little bit of history here. If you've seen any of the documentaries on the JFK assassination back in the 60s, Parkland is the hospital where they took John F. Kennedy after he was shot in downtown Dallas. So that's us if you've seen any of those documentaries. Okay, turn it over to Jack.
All right, everybody. This is Jack Wagner, and it's great to be on the call. And I really appreciate everybody taking your time out to be on the line today and talk about a topic that's near and dear to a lot of clinical engineering / HCM / biomed and IT security departments right now. And that is choosing a visibility platform that plugs or gives you visibility into the blind spot within the Internet of Things medical device realm. And so that's what we want to talk about today. It is a little bit newer technology. It's been around for a few years, but a lot of it still is still a mystery, or it's still not really looked at a lot of organizations, or a lot of organizations are just getting into it. And we at First, we have been doing this for a number of years. We've got a number of different customers with various of the platforms out there. And so what we do is we have found that a lot of organizations are in various different stages, and that can be anywhere from unsure how to approach this whole thing to begin with, or all the way up to somebody who has implemented and maybe is not using it or doesn't have it operationalized effectively. For Parkland, they had already seen various tools. Their IT security department had looked at a few tools, and the HTM team had looked at a few tools, and the group really decided that they needed to get together and put together an overall regimented program around a selection of a platform that would give them visibility into primarily medical devices as well as the other Internet of Things devices out there. And so they engaged First to come in and help them and use our experience around this type of platform and this type of program to assist them with growing and making this program into a project that could be easily measured. So using that methodology, Parkland's selection team performed a step-by-step analysis of their own organization. Starting any of these types of projects, you want to start with a current state compared to a future state. And many times current state is nothing and future state is we want full visibility into medical devices. And once you know what you want your future state to be, then you can look at a few of the vendors in the arena. There's probably 30 plus vendors in the arena at this point, maybe over 50 now. However, from our experience, we've really seen much less than that, probably less than 10 that are really competitive and do it pretty well, all of them with various different capabilities, depending upon what you want to see. So what we did was Parkland had already identified a few vendors that they wanted to look at. So we decided that we would start with those 3 vendors and establish what we considered success criteria for Parkland. What did they want to see each of these products do that they could measure? And then we followed those from all the way from vendor demonstrations through live side-by-side demonstrations, and also through vendor references and final competitive pricing. And finally, all that was measured into a final comparison. And we'll dig a little bit deeper into each of those as we go through the presentation. But I'd like Travis maybe to chat for a couple minutes about where Parkland was and what they saw needed to be done.
Great. Thanks, Jack. Appreciate that. So Parkland, we just recently moved. I say recently, it's been 5 years already. Time flies when you're having fun. But we were previously in the older building that was very old. And in that older building, we were a very old school, not very highly integrated hospital. We had a few random devices, very select devices that were actually integrated. Everything else was functioning as a standalone devices. We had our standalone networks, pretty much a status quo, unintegrated hospital as far as technology goes. As we moved into our new building, we built a new hospital, and we finished that project up in 2015. And when we started working on transitioning to the new building, we went from a very unintegrated hospital to a very highly integrated hospital. Basically, every piece of medical equipment that had a data port or a wireless capability, we wanted it on the network. We wanted to get it on there. We had a big, robust network provided to us, and that could support and accommodate all the additions, and we took full advantage of that. So as we work towards integrating all of our new medical devices as well as our relocating medical devices from the old hospital, we didn't really give it a lot of thought into cybersecurity. We were very focused on getting these devices connected, getting them talking to the network, integrating them with the EMR, so we're sending this data over. And cybersecurity was not really on the front of our mind. I mean, it was a factor, it was part of the process, but it was more of a checkbox than not so much of a well thought out process. It was kind of under the concept of get it plugged in, get it connected, get it working, and then we'll figure out security later on. A couple of years ago, we went to an AAMI conference, and that's when cybersecurity was first really taking root and really starting to grow. We met with a couple of vendors at the AAMI conference, and that was kind of our first exposure into this industry. And we quickly gained a lot of interest in that, and we started exploring options, technologies, capabilities. We were just flabbergasted by the technology, the capabilities of some of these systems. And so we knew we needed to get involved with this. We needed to find a system that worked well for us, that would meet our organizational needs. And the thing is, it was so new to us, like what Jack was saying, a lot of hospitals are in that same boat where it's a brand new concept for cybersecurity management for medical devices. We didn't know what we didn't know. So it was very much a discovery phase for us just to see what technologies were out there, what are the capabilities. So when you talk to any one of the vendors, and of course they're all going to tell you that they have the latest and greatest and the best there is to offer. Well, we wanted to learn for ourselves what are our options? What can we do? What we'll be looking at here for technical capabilities of these systems. So we met with a number of the vendors and just we used the initial demos to kind of develop criteria and grab the golden nuggets out of each one of those vendor presentations to see what we wanted out of our overall solution. That kind of gets us up to where we are right now. So I'll turn it back over to Jack.
Right. Thanks, Travis. And so what I wanted, Travis had indicated, and I had indicated that there are a number of vendors out there. A lot of them have their own stories and their own capabilities, and some of them have got great presentations. So one of the important things was for the Parkland team to figure out what the selection criteria was. What was the most important things that they should look at and score these devices on, these platforms on, to figure out which one would meet their needs the best. And I'm not going to read each one of these on the slide, but I did want to focus in on three of them. And the first one is passive scanning. Passive scanning is pretty critical because, as most of you know, being from a clinical engineering background, that especially as the cybersecurity has started rolling out for these devices and have become more of a concern, is that any kind of active scan or probing of some medical devices, they are so sensitive that it could knock them offline. And so the last thing you want is to be implementing a bunch of new tools that their whole job seems to be contradictory to keeping these devices online and taking care of patients. So one of the most important criteria is passive scanning. And passive scanning is literally where, instead of actively looking at these devices, that the tools or the platforms have access to the network, so they have network visibility, so they can watch the devices communicate between each other and their servers and various other systems. And then those platforms will read that data and pull it into their systems, and it will analyze it or scan it. If you've listened to any of the vendors out there, they have a number of different things they call it. Some call it artificial intelligence, some call it computer learning, others call it deep packet inspection. But what they're doing is really looking at whatever way or variation that they're doing it. They're scanning that traffic, identifying devices, what those devices do, medical devices, make, model, the actual serial numbers in some cases, and on and on. So they profile those devices and what their normal stuff should be. So passive scanning is one of the best requirements. Another one is integrations. With these devices, you want them to be able to integrate with existing security and HTM tools that will allow every section to get their job done and get the most value out of it. You don't want a flathead screwdriver that's only good as a flathead screwdriver. You want a tool that's going to be able to do multiple things and tie into other systems. So it may also provide data enrichment information to your CMMS, and it can also provide alerts and vulnerabilities to your security operations center folks. And then the last one I wanted to touch on in this one was business intelligence. You want to be able, any system that you have is great if it does its job, but if it also gives you information that you can use for other things and make business decisions based upon it, that makes it even better and more valuable. And so that's why business intelligence is pretty important. And Travis, I know that as we talked through the selection criteria in the very beginning, that we did work through some of these things and what you might find important in one of these platforms. So I'll just let you talk about it.
Definitely. Thanks, Jack. So I'm going to focus on bullet number 3 and bullet number 4 on your screen here. Some of the biggest things that we saw early on when we were evaluating these systems was the information that was coming across our network from these devices. By them doing their passive scanning and monitoring our technology, it wasn't just it was identifying the devices for us, which is a huge improvement, but it was also providing back information such as software revisions, serial numbers, security patches if there was updates needed. There's a lot of information coming in from our medical devices that historically we've had to manage all that manually. We've had to go out, put our hands on a medical device, see what OS it has, what is the latest software version, what is the latest security patching, so on and so forth. And you got an inventory we have roughly 35,000 medical device assets on our database. So managing that manually is next to impossible. And so the information coming out of our whatever selection we were going to make was going to supplement and enhance data integrity of our database. So that goes on to bullet 4. So having a tool for your scanning and cybersecurity management to integrate into your medical device database, your CMMS, is important because this could really help supplement and better tighten up your data integrity of your inventory. So our network visibility devices is helping us shore up our inventory of our IV pumps, what software version is running on each pump individually. IV pumps are just one example, but it applies to everything that we have on our hospital network, including our closed patient monitors, central stations, so on and so forth. Company viability ownership is a big deal to us. With all the vendors that are out there, it's a very competitive market, very tough market, and they all have, like Jack said, they have very good presentations. So finding the one that best meets our need was very important. Significant investment. We want to make sure we get the best bang for the buck. And we wanted to partner with a vendor that we know is going to be in the market for a while. We didn't want to partner with somebody, go through this big, massive effort to stand the system up, integrate it to all of our appropriate applications, and then have that vendor go belly up or sell out to one of your bigger manufacturers, so on and so forth. So that's kind of my points on this screen on this slide for the selection criteria.
Perfect. Thank you very much, Travis. So then we're going to dig a little bit deeper into each of the steps that I had mentioned earlier, and the first one being demonstration metrics. We wanted to be able to define a list of items that each of the selection staff would be able to look at as they looked at each of the vendors in the initial demonstration. Now, we had both mentioned that Travis had seen some tools and IT security had seen some tools too, but not all of them had seen each of the tools. So when we pulled the selection committee together, it was made up of people from Travis's clinical engineering department, the IT security teams, IT networking was there. So we had a pretty broad scope of technical people that were in the room that would be able to evaluate and look at these. And we defined that there were several metrics that were really important that we wanted to be able to measure. And those would further get down to what is the easiest, the easiest to use that provided the most information and that was going to hang around the longest amount of time. And so this was just, we use these same metrics for both the demonstrations as well as the live side-by-side comparisons. And in the demonstrations, it was literally that we set these metrics aside, and then we brought in each of the vendors to do their standard or their best case demonstration scenario in their lab environments and their demonstration environments. And at this point, they knew a little bit about Parkland in the background and what discussions they'd had in the past, but they didn't have a lot of in-depth information on what their requirements were. And realistically, Parkland, we were just at the very beginning of the system selection process. So they were still learning a lot as we went along this process as well. Travis?
So yeah, our key item on this screen here is that when we first started this path, we didn't realize how big of a journey it was going to be for us. We thought it would be just a quick make a selection and go on with it. We learned really quickly that we didn't have all the stakeholders at the table. So for any hospital that's going to go down this path and is looking to implement this type of technology in your organization, I urge your clinical engineering and your healthcare technology management departments to work quickly with your information security departments, your networking team. A lot of clinical engineering departments have merged with IT. Historically, we are not under the IT umbrella. We're actually under facility support services at our organization. But getting them on board and exchanging ideas and thoughts and with our information security partners, we were able to learn a lot more. We were able to corroborate and really discover that a lot of the things that we're trying to accomplish with our system, they've been doing it for years, but on a different level. They've been doing it with their computer devices and IT devices. So working between the CE departments and your IT department is essential in this. And we probably could have saved ourselves a couple of months on our initial project if we would have partnered with them earlier on. So that's very important.
So after the actual demonstrations, it became pretty clear that out of the vendors that performed the demonstrations, that two came out as the highlighted ones that should be continued on with, and so after that, we began to work with those vendors to get implemented into the Parkland environment. And we had a pretty big decision to make at this point. I mean, it was the right decision. It just required a little bit more work. A lot of times in a bake-off or a system selection, you might install a product for a little while, then deinstall it, and then install the next competitor. But we can't really stress enough how important the success of a selection is in this type of environment, to put both platforms on the network live at the same time and literally compare them side by side on a regular basis. It took quite a bit of coordination with various IT teams. You got to make sure that there's room in the data center, proper power and cabling and cooling for these devices. And you also have to ensure that they have the exact same visibility of the network. And that could differ between your different organizations. An organization may have the ability to give these devices full visibility of their network right off the bat. Other organizations might be spread across the country in different cities and just have all kinds of requirements for not being able to get one appliance. So they might just choose to look at a part of the network that is heavily populated with medical devices. Whatever the case may be, it's just important that both platforms, or how many ever platforms you put in the bake-off, recommend usually 2 is the easiest, that they have the exact same visibility. And then once they're both up and running, let them gather data for a few days, and then you can really begin the comparison. Another important thing that was done with this was everybody on the selection committee had a login account to both of the final platforms. So nobody was limited to just meeting once a week and viewing them side by side. Everybody had access to where they could go into each platform day by day and start mapping out what their potential future workflows might be using these devices. And when you compare them side by side, we actually came across with a number of things, and I know that the Parkland staff was pretty surprised whenever we first started looking at them, and the differences in number of devices found, which platforms identified the vendor best, and how deep did they go into the information for each of those devices, even as much as did they find serial numbers and attached modules. And just the ability to report that data out and make it available to everyone. And we also went through each of those comparisons. We met on a weekly basis, and during those weekly meetings, we would focus on one particular area. One week we might focus on dashboards or reporting, and the next week we would focus on vulnerabilities and how they were identified. And then the next one, it might be alerts or device utilization. So there was a lot of time and effort that went into the bake-off comparison, and it's really best to let it last for a little while. Travis, what did you think about the bake-offs and how they all went?
Yeah, I think the bake-off was a great idea, and I love the way we rolled that out and managed that. I think it went very well for us, because a lot of these systems, they have, the vendors will have very nice presentations and very good graphics and a lot of promises, but we wanted to see it in action. So we had our top 2 vendors plug in their systems, stand them up on our network. We read them side by side, just like Jack said, and it was very interesting to us to see. You would think in an ideal world that both systems would have found the exact same number of devices. Well, we found that's not necessarily the case. And some of it has to do with the technology on how the vendor systems detects. I think some of the technologies are relying purely on MAC addresses. Others are relying more so on the behavior of the equipment and what it's sending, what type of information it's sending over the network. For example, you may have a CT scanner. Well, the CT scanner is not plugged into the network. You have a computer that's built into that system that is plugged into the network. So it's possible that a system could pick up that device as a computer, not necessarily as a CT scanner. So those are some of the case scenarios that we had to figure out. But when we saw the inventory discrepancies, we just looked for the things that stood out to us, the most obvious and variances in inventory quantity. And we dug into the details to figure out why each system would see or not see that specific device. So that was something very important to us. Just we want to have reliability and consistency in how the system detects our inventory. Basically, there's a lot of functionality that we were looking for specifically that we were able to actually live a day in the life with it basically during this bake-off. And we would have both systems stood up side by side on our computers, and several of us were in both systems at the same time to each get our own perspective of what was going on and what we were gathering. Some of the big features out of this that we were learning was the ability of the systems to provide software revisions, OSs, so on and so forth. One of the big things we were able to see that was very valuable to us was by this system being able to identify medical devices by serial number and also by software revision, that enables us to much more effectively manage our FDA recalls. So that's something kind of unique to the HTM world and the CE world that IT doesn't have to get involved with very often. Medical device recalls, it's a very cumbersome process for all of us that has a significant inventory. It's a very manual process, having to go back and look at your device inventory, looking for a specific manufacturer model, serial number range, software range, and this system here was able to pull that information for us. So some of these vendors, you'll see that they have a service that goes along with the product, usually on a contractual basis, that they will provide and feed in FDA recalls and alerts into this application, and it will automatically sniff out of your inventory which are your affected devices. So if a FDA recall comes out affecting a specific serial number range for a specific type of IV pump, some of these systems will detect those specific devices, and if you have a good integration into your database, your CMMS database, you will be able to trigger work order notifications for the specific devices that are affected by the recall. That was a very big value for us in the systems as we were evaluating. The other key feature was utilization. So utilization is something that was a big sell for us because I can't think that we're alone in the world in this aspect, that we're always looking to acquire more inventory for whatever devices. One of the big features, well, here's an example, like our CT scanners. So we currently have 10 CT scanners. Some are dedicated for inpatient, some are for outpatient, and some are for special procedures. There's always a press to get more CT scanners to add to our inventory. We get a lot of pressure from our radiology leadership, from our doctors, and we have not had historical solid utilization data to justify and really show our current utilization of our existing fleet. CT scanner costs $2 million. Okay, well, by using the tools in this database, we're able to see realistic numbers and metrics for utilization. We were able to see hours of use, peak hours of use, how many cases per day, how many procedures per day, how many images per day, so on and so forth per scanner. And all this was presented in a graphical data. And we were able to reproduce this data to our executive leadership. And basically by having this tool, having that utilization functionality built in, we were able to not buy additional CT scanners and save that $2 million. There was pretty much a run for buying an additional CT scanner. It was $2 million for the scanner, about $1 million for construction. And by having this tool installed and available to us, we were able to present hard data to our leadership to make a educated and informed decision to not buy a CT scanner. We were able to juggle patients around, juggle the way they distribute patient load, and make full use and efficiency out of our existing inventory. So cost avoidance was a big thing for us. So the system costs money. It does cost some money. They're not cheap. None of them are. But if you have a good utilization built into your system, it will get an ROI in cost avoidance. Like IV pumps is another good example. Without going into too much detail, tracking our IV pumps, we're always getting pressure for, we need more IV pumps. We need more IV pumps. Well, we found out by using these tools on our new system that our IV pump inventory utilization is typically around the 30 to 35% mark. There's no way anybody would feel comfortable signing off on a couple $1 million purchase order knowing that we have 75% of our inventory not in use at any point in time. So this gave us good solid data to go back and revisit our processes for managing and distributing IV pumps throughout the organization. So that was another cost avoidance scenario that we benefited from the use of this technology. With that, I'll turn it back over to Jack.
Right. And I know that we're a little bit over our promised 30 minutes before we hand it over to questions. So I'll pick up the pace on these last couple parts just so, but they are important. One was training sessions, and Travis, I believe that you'll likely agree as we went through this, that the selection committee learned more and more as you went along. So we started off with training in the demonstration, and then whenever the bake-off started, we went ahead and had more training. And as I stated earlier, first, we've got multiple customers with multiple different platforms, so we were familiar with these devices. So we were able to also provide familiarity training along with lockstep with what the vendor could provide. And this lasted, we probably kept them together approximately 3 months as we were doing the measurement and the side-by-side comparisons. And as we went through there, the team was really engaged. They got very involved, and they learned more about the system. So their questions got deeper and required more information. So then we had more training by the vendor to come in and start answering these more complicated questions that were coming up as people came familiar with the system. So it is a part moving from the familiarity to actually having in-depth knowledge of the system and being able to use it, but it does come pretty quickly with these tools. Travis?
Yeah, training was a big deal to us. Having a vendor that's fully engaged and supportive and that's going to help you learn, because like I said before, this is new to most of us in this industry. So having a vendor that's very supportive and understanding of our environment was very important to us. Also with that, we were in evaluating our systems during the bake-off. User friendliness was important because we wanted to get this out and get all of our clinical engineering staff using it. And, you know, we give them a lot of applications they work in, from their CMS system to our purchasing system to a number of other applications. We're adding one more application to the mix. So it was very important that we have a very user-friendly system for our staff to use. And having a vendor that's very supportive in adapting to your user-friendliness needs, as well as supporting with education, is a critical point in this.
All right, and I won't spend a lot of time on this slide, but I did mention that everything needed a score, and everything, we defined metrics, and so it was important to score throughout the progress of the project, especially when you've got a project that lasts several months. You're going to forget what happened on demo day, and maybe forget what happened in the first couple instances of side-by-side comparison. So it was critical for us to make sure that we, one, tracked all the scores, but two, that we had a methodology that gave importance to what we thought was the more critical aspects of the technology. So you'll notice here the scoring methodology. This is literally weighted sections. So we gave 50% value to the proof of value live comparison scores. We felt like that ease of use was incredibly the most important part of the entire selection process. And then we gave the second highest 25% to the use case scenario demonstrations. And I said that the demos were where they gave us their canned demonstration, and then we started live, and then we moved into use case scenarios where we actually told the vendors what Parkland wanted to see and wanted them to prove. And then we had use case scenario demonstrations. The vendors had the questions and the scenarios prior to it so they could prepare and make sure that their product, that they could show us exactly how their product answered each of our use cases and made those happen. Travis, do you have any thoughts on the scoring?
No, I think it's a very well thought out process in how we scored. I think it was fair. I think it gave all the vendors the opportunity to present their technology, and it met our needs perfectly. The way you have it balanced out here worked best for our organization, and we thank your group for guiding us on that. It worked very well. Thanks.
No problem. And then we're to the last slide where you guys have to listen to me and Travis yap along in this, and then you can start asking questions. I see there's a couple questions flowing in already. The final part, of course, was a final decision analysis. And so during the selection, first, who we program managed the entire selection. Now, I should start by, we didn't make any recommendations as a company as first to Parkland as far as what products. We didn't steer or vote or any of those items. We literally just put together the process and helped put the form and the management around it. So Parkland, all they had to focus on was looking at the products and scoring the products. And then we would take all that information and we put it all together. We scored them all. We aggregated all the scores. And then we put together a final scoring summary along with a comparison chart that showed some of the, positive and negative reviews that were given by the Parkland team. Because as I stated, when it lasts for a little while, you forget what happened in the very beginning sometime. So this comparison and this summary was able to remind the entire team of what had happened and what scores had been given to each device along the way. And the final scores were really representative of what the team saw during that entire time. And I should also note that that's not necessarily a final decision factor. I've done a lot of platform selections, not all for these type of platforms, but for various population health and EMRs and other types of system selections. And sometimes the team gets so knowledgeable by the end of it that they decide that they want to look at another product altogether. Or the product that necessarily didn't score the best seemed to be the best fit for them because it might have had a feature or a future roadmap that the other one did not. So there's a number of things that can happen. I'm happy to report, though, that with Parkland, because ultimately you go through a system selection, you want to select something at the end, and you want to know that all the work that you put into it came out as something. And so I'm happy to say that at the end of this selection, the team, they were presented with the information. There was some discussion, and I laid out the options for them, what next steps was as the program manager, and they were ready to vote. And they made a unanimous selection of the Medigate vendor. And so, Travis, I'll let you talk a little bit about how that went.
Okay, thanks. So on the final selection, it was tough, and there's a lot of good vendors, a lot of good technologies out there. So it was a pretty tough thing for us. But like I said before, that the key things to our organization, I mean, of course, any one of these systems obviously should be very efficient, very effective in managing the cybersecurity aspect. But it's all the value-added functionality that kind of tip the scales for us. The utilization metrics and performance analytics, the FDA recall management, those are some of the items that made it more of a slam dunk for us to go with the direction that we went with Medigate. It was interesting when we reviewed our final scores. Everybody was pretty much in line. We all felt in alignment. There was no divided or split decisions on anything, pretty much. So I feel like the process went very well. Having First Health Advisory on board to help us was very key to us making it a success, because like any other hospital, especially right now with all the COVID activity going on, our departments are going in all directions, 100 miles an hour every day of the week. So projects like this that don't have a lot of clinical leadership screaming and yelling at us to get it done, get it done, get it done, sometimes tend to get put on the back burner. And so having First Health on board with us to guide us, keep us on track, keep us on schedule, gather our notes, gather our scoring, it helped make this project a success for us. And we're very appreciative of that.
All right. With that, I will hand it back over to the staff to take the questions.
Well, thank you. We've got several that have come in, and I'll go ahead and let them rip. For Travis, it's obvious that Parkland executed a rigorous evaluation process. Now that you're using the platform, can you share any early benefits or surprises that you have seen?
So yeah, early benefits, it was amazing to us to see how many devices we actually had on the network. Like I said, when we first moved in this hospital, we were just running wild, plugging in devices, getting them connected and integrated. And we didn't do a real good job tracking our activity at that time and documenting in our database. And again, it would have been a manual documentation process anyways. But plugging the system in, letting it run, within the first couple of days, our eyes were about popped out of our head, seeing how many devices we actually had connected to the network and the level of detail and clarity as to what these devices are. They're amazingly precise and accurate as far as managing our inventory. The numbers detected on the network versus what we show in our Navolo database, it was just impeccable in how accurate it was.
Thank you. For Jack, do you think the size of the organization, the health system, impact how long it would take to run a selection process like you did for Parkland?
You know, it doesn't have to. Typically, my initial response to any question like that is it depends. And it really does. It depends on a few factors. The first factor is the organization, is the network infrastructure prepared to take on a couple more platforms, even though they don't have a lot of requirements, but are they prepared to take on a couple more platforms that they can mirror stuff to? The next one is, what is the scope of what you want to see? Is it just medical devices, or is it all IoT, like facilities devices and lighting systems and security cameras? If so, even a large organization, instead of opting for 100% visibility, they could opt to find one or two networks that are heavy with those types of devices, and just allow those appliances to see those particular networks. So no, if you're a really large, complex organization and you think that you've got a couple good parts of the network that are indicative of what should be seen through the rest of it, you can still do this in the 3 to 6 month time frame. You could do it quicker. We found that 3 to 6 months is more of say the magic time, because that gives you plenty of time to learn the systems as you go along and really be able to dig deeper into them as well.
As a follow-up to that, Jack, because so much of the evaluation was really hands-on experience with the tools, but I think it would be interesting to note your experience with regard to how much of a heavy lift was it to stand these systems up? Was that, I know it's going to vary health system to health system, but there's a general thought, I think, that, you know, this is a lot of work to get these things going, and I'm not sure that's accurate. I'd be very interested in your perspective.
You know, that's a great question. It is more a lot of work to make sure that you've got rack space, power, network, and cooling. More places than not, I find out that it's not the platforms themselves, that take a while. It's getting the infrastructure ready for them. The actual implementation of the platforms, and I'm not overstating this, there is some initial information that everybody needs as far as port mirrors and different types of ports to connect to the cloud, but that isn't a significant amount of information. Once the network is ready for these devices, then you can slot them into one U in a data center, and that may not mean a lot to a lot of people that don't work in the data center, but they don't take up much space, they don't take up much power. And once you turn them on and they have network visibility, they start gathering data right away. So the implementation of these tools is actually pretty quick to start getting visibility. Time starts expanding a little bit when you start working into the data enrichment integrations. But just getting the visibility that Travis has talked about, all the benefit he's got from, that happens rather quickly and easily.
For Carter, and to Jack's point, getting at an accurate inventory, even finding vulnerabilities, these tools do a nice job at it, but it does sit on the network. Travis talked about the importance of cross-functional representation in the evaluation process. Could you expand on that? Does IT or security typically own the technology and drive the evaluation in your experience?
Yeah, and we have something that we call organizational integration, which is really key to the success of using this platform at the enterprise level. But in some organizations, clinical engineering, biomed, HTM, they report up through the same leadership as IT and security. So the accountability and responsibility matters are kind of more streamlined. Where other organizations, they report up, just like Parkland, through separate structures and kind of warrant more discussion and conversations related to budget, management of the platform, FTE counts, and the roles and responsibilities, even risk mitigation roles. And so I would say it's more common for the platform itself to be managed by the network security team. After all, it's a technology that assesses network traffic. But then the HTM side has role-based access, to view everything that Travis has discussed here today. And I'd say regardless, there's a lot of downstream or workflow considerations to be addressed between those two primary stakeholders when you determine, who technically owns the platform.
Right, I see some more questions coming in here, Carter, and I think some of them you would know best how to distribute. Why don't you take a few of them?
Yeah, this one actually sounds really good for Travis. What portion of the medical devices were you able to get the serial number off of from these scans?
Okay, so right now it's probably, I'd say about 50% of the medical device inventory we're grabbing a serial number. We have a lot of NAs currently, but we're still working on operationalizing the system. So the devices that are showing an NA under serial number, we're not sure exactly why, because we're still going operational with it. And some of this could be to how the devices are categorized as medical devices. Some of these devices we don't categorize as medical devices in Parkland, but the system does identify as a medical device. So that might be part of that delta. I think roughly we have a little over 9,000 medical devices detected currently, and about half of those have serial numbers in them.
All right. And another question that came in was related to your comment on pump utilization, where I believe you noted Parkland was at about 35%, kind of a surprise to you. And if I'm interpreting the question right, they're asking, were all 100% of the pumps actually available for use? Or, were they, some of those 100% in maintenance? And so is that information that you're able to glean from the tool?
Not necessarily. Basically, by having the system integrated with our database, we will be able to have more clarity on that. So basically, what we're working against right now with the data we're provided, we're able to determine we have 1,500 of one specific module, for example, our Alaris LVP modules. We have 1,500 of those on our inventory overall. By using this tool that we selected through Medigate, we're able to see that of our 1,500 LVP modules, on a daily basis, roughly 50% of those modules are connected to the network and sending data, meaning it was utilized at some point during that 24-hour window. So that's 50% over a 24-hour period. However, there's a more granular view where we can go into an hour-by-hour basis, and we see that on the hour-by-hour snapshot, we never have more than 200 LVPs in use at any point in time. So by knowing at any point in time throughout a 24-hour period, only 200 out of our 1,500 are actually in use on a patient, and only half of our inventory on average is touching the network every day, that showed us very clearly that we have a distribution problem. And we found that most of our pumps, we do have some of our inventory out for maintenance, but it's usually a small, maybe 2% or less, and out for maintenance. The rest of it is in various stages of processing. They're in dirty utility rooms. They're in transit between the floors in our central equipment distribution garage. It's just various phases of processing. Or when you have a 1,000-bed hospital, and if you have one or two modules in every pump room, well, there you go. There's your inventory right there. And in our scenario, we found out that our pumps there was not a pot of gold at the end of the rainbow where all of our RV pumps were hiding from us. They were just spread out in onesies, twosies throughout the organization, and that's what's contributing to our perceived IV pump shortage. So with that data, we're working with our equipment distribution department to come up with a better refined process for determining PARs, so on and so forth.
All right, and time for one more question, and I'll try to interpret this. How were the legacy systems considered in the evaluation? And I think what's being asked is legacy devices here. And, you know, if you can't patch them, you don't have compensating controls necessarily. You know, Jack, Travis, how were those type of devices kind of considered in this evaluation?
So I'll take part of it and let Jack chime in as well. So the legacy devices, like we have older systems that are connected to the network, they're probably violating all sorts of information security rules. We have a number of those, to be honest. And the beauty of these tools is that if we cannot install patches, there are no software upgrades. It's on an out of support Microsoft OS, so we can no longer do any updates on. The tool will monitor that device's behavior, and if it does any sort of suspicious, potentially malicious behavior, like it's talking to a inappropriate IP address somewhere in the Netherlands or somewhere in wherever in the world, it'll throw up a flag. It'll be integrated with our Cisco Prime, to where it'll throw up a flag and notification to the appropriate teams, and we will be able to investigate, or even in some scenarios shut down that port to stop that traffic. So even on the devices that we cannot push patches onto, it gives very good tools for us to be able to monitor and manage those risks. Hope that helps.
Okay, I think that's it.
It does. I have nothing to add, Travis. You might be gunning for my job, man.
If they pay better than mine, we'll talk.
Well, I think we've hit the hour, so I'll turn it back to Amy to close up. But again, for everyone who attended, we appreciate your attendance, and we look forward to any feedback that you can provide to us so that we can continue to improve. Have a great day.
Thank you all.
Thank you, everybody.
Thank you, everybody.
This concludes the webinar. Thank you for joining. The next cybersecurity track webinar will take place next Monday, July 20th at 2 p.m. Eastern Standard Time. Again, thanks and have a great day.